So, thanks,
Next,
Dr.
I
Modi.
invite the next speaker, Dr. Mallika Goyal. She's retina and uveitis consultant at Apollo Hospital, Hyderabad. She'll be talking to us on retinitis and HIV patient step-by-step management. She has vast experience in handling HIV patients. Over to you, ma'am.
Thank you very much. So, retinitis only. I'm not going to speak about choroiditis and granulomas. In HIV, immune compromise leads to opportunistic infections, which are usually a manifestation of disseminated disease elsewhere in the body. And antiretroviral therapy often unmasks these infections by causing inflammation in a previously quiet asymptomatic eye. Most common is HIV microvasculopathy, seen usually with low CD4 counts, does not have any visual significance. The infection most common is CMV retinitis with low CD4 counts, has a cottage cheese and ketchup appearance because of the granular necrosis with hemorrhages. The importance is that it identifies that this patient is an AIDS patient, not only HIV infected, but AIDS, and the need to start ART, or if they are already on ART, that has to be improved. Vision loss is common due to extensive retinal necrosis, optic atrophy, macular scarring, and retinal detachment. It could be very mild, occasional patches which can be missed. It can be neuroretinitis, retinal vasculitis, or in relatively less compromised patients, it can be just iritis. And these patients, you can suspect that this is CMV anterior uveitis and be on the lookout for retinitis. Some of them have severe vitritis where you cannot see the retinitis but have to have clinical judgment. Very often in viral retinitis, we see proliferative retinopathy because of extensive vasculitis causing ischemia. So they present with NVD, NV, vitreous hemorrhage, neovascular glaucoma. So apart from treating the retinitis, we also have to take care of anti-VEGFs, laser, and vitrectomy if needed. Treatment of CMV retinitis is intravitreal ganciclovir for immediate action and then maintenance with oral valganciclovir. In resistant cases, foscarnet or cidofovir. But ultimately, these will only for 2-3 months or 6 months, but the long-term resolution will depend on improving the immune status with ART. Intravitreal ganciclovir is obviously more effective, and the newer dose recommended is 5 to 6 milligrams once a week. Earlier, we used to give 2 milligrams twice a week, but now I have shifted completely to 5 milligrams once a week. Works very well, reduces the number of injections. Now, this is to show that a patient on oral Valgan does not improve macular threatening retinitis, but as soon as you give intravitreal, within 5 days, it's very good. Similarly, if with retinal detachment, there's an urgent surgery indicated. You need to get it urgently under control. So intravitreal injections and immediate surgery is possible within 5 days. Resolved retinitis, reactivation very often happens when the immune status drops again. And it happens at the edges of the resolved retinitis. And even after the retinitis has resolved, they need monitoring because the atrophic retina can develop breaks or large areas of retinal loss leading to detachment. Peripheral detachments can be managed with laser demarcation. But when they have to be operated, plan long-term oil tamponade for which you need to remove the lens because it will form cataract and have a higher viscosity oil for lower emulsification. And remove oil only when there is a CD4 counts have improved, there is a less chance of recurrent CMV infection. This is how it often looks like a sieve where large multiple breaks. The entire area can be treated like one large break and lasered with one demarcation row. And they can tolerate oil very well for several years, most of them. Immune recovery happens in these patients even after surgery. They develop cystoid macular edema because of ART, and steroids can be given if the physician approves the immune status. Acute retinal necrosis, Dr. Mudityagi has already described, so I will not talk much about it. Only to say the etiology is mostly herpes viruses, but the classical triad talking of peripheral vasculitis, peripheral retinitis, vitritis can completely misguide us into ignoring the disease, possibility of disease when we see scleritis, severe pain, iritis, and it completely masks the posterior disease. And sometimes the retinitis is primarily posterior pole, and again that's still ARN. So it's important to remember these points. Very often these patients can develop retinal detachment and require surgery. treatment is intravenous acyclovir or oral val acyclovir. Steroids in HIV patients have to be based on physician approval, and intravitreal ganciclovir also works very well. Again, PON described already by Dr. Mudit, so I will not talk much about it. It's a blinding disease, very rapidly progressive, seen usually in very low CD4 counts, highly immunosuppressed patients, and caused by herpes group of viruses. Pneumocystis carinii is usually picked up on routine screening, causes these coin-shaped subretinal lesions. They do not have any visual significance, but alert us to the possibility of pneumonia, which requires pentamidine therapy. Toxoplasmosis in AIDS is slightly different from regular toxoplasma. They have larger lesions, may be more difficult to distinguish from other infections because it's atypical, and can be bilateral, multifocal, with recurrences as soon as we stop treatment, and can be often associated with CNS involvement. We can also see retinal abscesses as bilateral, extensive, rapidly progressing to panophthalmitis as part of endogenous endophthalmitis. And often we can see two different problems in the two eyes of a patient, CMV retinitis in one, endogenous endoph in the other, or immunosuppression-related malignancy in the other eye with CMV in the one eye. And lastly, masquerade in immunocompromised patients. These can be very young patients presenting with bilateral intermediate uveitis, subretinal deposits, retinal vasculitis, not responding to steroids. So suspect in any non-responding intermediate uveitis. And if it's an immunocompromised patient, CNS involvement is common with poor prognosis. Thank you.
Thank you, ma'am, for the nice talk.